Hello, and welcome to today's webinar, Redefining Breast Imaging in the Enterprise Era, Tailored Tools, Connected Teams, and Embedded AI in partnership with AGFA HealthCare. My name is Brian Casey. I'm Managing Editor of the Imaging Wire. Got a great program for you today. We're going to start with a discussion with our panelists, and then we'll open it up for questions in the second half of the webinar. You can ask a question at any time just by using the Q&A button at the bottom of your screen. Our webinar panelists are Dr. Jay Patel, a radiologist and breast imaging section head at Quantum Radiology in Georgia, Kyle Souligne, Director of Enterprise Imaging Radiology at AGFA HealthCare, and Collin Bauer, Senior Clinical Consultant at AGFA HealthCare. Everybody, thanks for being with us today.
Thanks for having us.
Thanks for having us.
Yep. Thank you so much.
You bet. So let's start with introductions. Dr. Patel, can you tell us a little bit about yourself?
Yeah, I'm Dr. Patel from Quantum Radiology based out of Marietta, Georgia, part of a large private practice with close to 100 radiologists that are all subspecialty. And I'm the breast imaging section head for the last 8 years and also involved with AI and technology evaluation.
All right, very good. Kyle, how about you?
Hi, Kyle Souligne, Director of Enterprise Imaging Radiology Solutions at AGFA HealthCare. Been in the medical imaging space about 20 plus years. Primarily in my role, I work with physicians like Dr. Patel on really making sure that our solutions work for them and, make them as efficient and productive to deliver patient care throughout, the practice as well as with healthcare providers.
All right, very good. And Collin, how about you?
Yeah, my name is Collin Bauer. I'm Senior Clinical Consultant at AGFA HealthCare. Come from kind of more the clinical space as well. So CT and X-ray are my background. And really today, again, kind of focusing similarly to Kyle of, what we can do in the market to really make your providers more efficient and also kind of increase those patient outcomes.
All right, very good. All right, so let's dive right in. So I think everybody in radiology knows that breast screening and mammography are probably one of the most challenging things to do in radiology, if not all of healthcare. Dr. Patel, can you talk about some of the challenges that you're seeing, every day in your practice?
Yeah, so in our practice, and I would say probably across the board nationally, we're just seeing a lot of pressure from rising patient volumes. There's an increased complexity of the regulatory requirements that we have to even interpret breast imaging. Those rules are always changing, so we always have to stay up to date on those. There's really an expectation to deliver highly specialized reads and sometimes even with limited staff. So ever since COVID, really there's been like a difficulty to retain and keep even technologists in one location. And there seems to be a lot more travel technologists. So really there's a high turnover in the staff that actually performs the work. There's also more demand to serve remote areas that may not even have radiologists in the close proximity, but they do have computer systems and they do have imaging systems and they do need help in those areas as well to interpret mammograms and find breast cancer and treat them accordingly. So we're seeing a lot of pressure there, but the difficulty is just having more to do with less people to do it.
And so you mentioned the workforce shortages that happened during COVID, and that was a pretty big story. That was a pretty big story then. Are you continuing to see that?
I mean, it's definitely improved. I mean, there's definitely more ability to hire technologists, but it's not like they're all staying permanent in one area most of the time. There's a lot of flux in the areas that we cover, which is good and bad. Some technologists who travel are quite excellent. But it's really nice to establish rapport even with your technologist when you're a radiologist, so you can trust how they perform things, and they're easier to communicate with and kind of mold into the best they can be.
So you're saying you're using quite a few more travel technologists to kind of deal with a lot of the turnover and that kind of thing.
That's correct.
Yeah. Kyle, can you speak to how rising mammography volumes are affecting image management from the image management side? Because, mammography images are pretty big. These are some of the largest images in radiology in terms of file size. I would have to imagine that presents a lot of challenges on the IT side for like how we store these and how we send these. Can you speak to that a little bit?
Yeah, absolutely. Dr. Patel is spot on. Exam volumes are rising, and the complexity of the cases and the file types with Tomo and, ABIS and other multimodality specialties is a layer of complexity that enterprise imaging specialists like AGFA have to maintain. Modern technologies, obviously, that we're providing within inside of our viewing solutions make this a little bit easier. But I think the volumes in and of itself are really where we kind of have seen a lot of focus on how we're helping maintain that workflow for the radiologists. So not just delivering the images in a rapid fashion, but adjusting towards this rising volume. And I think from an enterprise imaging perspective, meeting these volumes that are rising because we're seeing more patients being brought into the specialty earlier with earlier screening, mandates for patients now, starting biennial screenings around age 40, as well as those breast density scores creating more images with ultrasound follow-ups. What we see from the patient side, obviously, is this causes younger patients. So patients in their late 30s and 40s that are more digital native, they expect faster answers. They expect reports in a rapid digital way, those report findings in a way that makes sense for them. And ultimately, we're just trying to work on the balance of that, providing the solution with the provider and the healthcare organization so that they can provide a real smooth transition of getting the report to their patients in the right time so that they're not looking over those reports and then talking to their favorite AI chatbot for a week before they actually review those results with their primary care physician.
Right. Collin, can you speak a little bit to enterprise, the role of enterprise image management in maybe smoothing over some of these challenges? Because, one of the other trends that we're seeing a lot in radiology is facilities moving, away from PACS, which was just a way for radiology to manage its images, into a more enterprise image management system that encompasses the entire healthcare institution. But breast imaging has its own unique workflow. So how are we integrating that breast imaging into enterprise imaging, and what's being done there?
Yeah, sure. So, and even as Kyle had just kind of mentioned, when we're talking about breast workflows, we're really looking at more than just kind of traditional mammography, right? We're adding things in like tomography, ABIS, just regular ultrasound, MRI as well. And so really it kind of comes down to access, right? That unified enterprise imaging solution really streamlines your access across those modalities, but also between your other locations that may be doing, as Dr. Patel said, some of those rural or smaller community hospitals that they're now reading for, getting access to those images is huge, right? So really just helping to manage all of that imaging in more holistic fashion, and really reducing, what we see in the field, a lot of toggling between different systems or different packs. We want to kind of remove all of that, right? To really provide some consistency in the reporting and the image viewing pieces. That's really important when we're talking about multi-modality breast care.
Yeah. Now, you mentioned multimodality, and you mentioned a couple modalities, things like breast MRI and automated breast ultrasound. And so one of the things that has been really interesting about breast imaging is how many different modalities are being used now. And it's not just X-ray based mammography. You've got all these different tools based on whether a woman has got dense breast tissue or things like that. I guess, Dr. Patel, can you talk a little bit about, is this a challenge deciding when to use these modalities? And then maybe, Collin, if we can segue into you and you can talk about how do you manage that from a, kind of an IT perspective, all these different types of images?
Yeah, sure. So, I mean, I've been practicing breast imaging a long time, and it's evolved a significant amount even since I finished training in my breast fellowship in 2011. And we really started in our practice with AGFA, and all we had at the time was, it was basically 2D mammography. That we didn't even have tomosynthesis quite yet. And somewhere around 2014, 15, we incorporated tomosynthesis because the breast imaging community was just realizing, like, this is almost like the standard of care. But that also meant a lot more images, but that's better for the patients because we have increased sensitivity for detection of breast cancer, where, we can see things better. We can decrease our callback rates, but also increase our detection of breast cancer. And that's why tomosynthesis was so important. And then as things evolved, more and more people were starting to pay attention to breast density. It's harder to see through dense breasts. So these patients also need supplemental screening with either, whole breast screening ultrasound, ABS, or screening breast MRI, which is what we prefer patients have, just based on, our belief that breast MRI is better at detecting, breast cancer than ultrasound. But all of this is complementary. It really depends on the patient and, kind of what they want as well. Some patients don't even want a mammogram. They would rather just have a screening ultrasound or just a screening breast MRI. So you really have to have the option to address any patient's needs, but also staying in tune with, ACR recommendations. So we will still recommend screening mammograms every year. We will recommend that they have 3D mammograms. And if they have dense breasts, we will recommend, or at least discuss with your provider if it would be a benefit for you to have some type of supplemental screening. But all of this means there's a lot more imaging being done. All this means we're detecting more breast cancer. The volumes are definitely increasing, but we also have to have the ability to see all these things in one unified place, like we were describing with AGFA EI and like a comprehensive system, without having to go to like 3 or 4 different places just to interpret this stuff. So from a radiologist perspective, and even another clinician's perspective, everything needs to be smooth and streamlined, and you have to really have everything at your fingertips without delays. And so that's where we need the help of everybody at AGFA to make sure all that stuff's running smoothly and be able to handle the load of all these increased imaging requirements.
Collin, from a vendor's perspective, is that difficult to do? Because a lot of these modalities are really different. I mean, some modalities like breast MRI, they're dynamic. You've got moving images. You've got ultrasound. How can you integrate all this stuff into one presentation screen to the radiologist that kind of makes sense to them?
Yeah, so I think kind of the biggest thing that I'm picking up from Dr. Patel, that each of those modalities that we're talking about then can also have separate workflows by themselves, right? We're talking about calling patients back or not. We're talking about, do we do a breast density ultrasound versus an MRI versus, a routine mammogram? So really, when we're talking about integrating all of those things, not only is it that image of the delivery, the delivery of those images to the radiologist, but really also how do we make sure that they're being delivered, in the right part of the workflow for that patient care. So, when we're talking about an enterprise imaging platform, additional modalities like ultrasound, MRI that we're talking about can exist in those same kind of workflows that we know traditionally with mammography, and really just kind of enhanced. Again, just to reduce that fragmentation to help those radiologists really interpret those cases kind of in context of the larger, imaging breast health.
Yeah. Now, Collin, in the introduction, we talked a little bit about some of the challenges with the workforce, and
Sure.
Everybody out there in radiology knows that how challenging it's been to hire and retain people. Is there kind of an IT solution to this? So as breast imaging practices are dealing with rising volumes, can you do things like routing screening cases to certain radiologists, so more specialized mammographers are taking the more challenging cases? I mean, what can be done on the IT side to sort of optimize the way people are working?
Yeah, certainly. And again, it does come back to that workflow, right? And we know that those growing volumes of radiology, and especially mammography, as we've kind of discussed earlier, that workflow optimization really is super critical, right? So we've kind of been talking over the last couple of years about things like workflow orchestration rather than just kind of a rudimentary work list, right? That really kind of overloads the radiologist now with how many different modalities and things that they have to read. We really want to streamline that. And we know that that's not even a one-size-fits-all problem, or even a one-size-fits-all solution, really, that each institution, based on their volumes or their staffing, may opt to solve these problems differently, right? And you actually used a great example, some of those medium-sized institutions who have very few, maybe 1 to 2 breast radiologists, right? They may need to intelligently route those routine screening exams to their general radiologists, really to kind of preserve the specialized breast imagers' time for those more diagnostic or complex cases. Like I said, overall, we really just want to offload a lot of those mundane administrative tasks that the radiologists are having to do just to find that next case to read, right? And give them time back to really do what they do best, especially when we're talking in breast imaging, as Dr. Patel mentioned, with the technologists, even they work in a much more clinically consultative role, both with their staff and their patients alike.
I just wanted to remind everybody out there, we will be taking questions from the audience in about 15 minutes. So you can use the Q&A button at the bottom of your screen to ask any questions. So Collin, let's get back to workflow again. Do you see a big difference between screening workflow and diagnostic workflow? Because they're two kind of different.
Yeah, definitely. They have kind of their own workflows, right? We know actually Dr. Patel's group has it. They manage it pretty well, right? Depending again on the institution, how they prefer to read. If they have those trainers who are those who have been more trained, more specialized to do more diagnostic breast, they may opt to kind of, segment out those different workflows, whether that's another work list or we just kind of, automatically assign those cases to them so that, again, they're not having to hunt those things down. We do typically see kind of a deviation between the two of them. And even if it's the same radiologist, just day to day, one day they may be on screeners, another day on diagnostics, right? So, yep.
Very good. So, Dr. Patel, let's talk a little bit about AI, because AI has been so prominent in radiology. Everybody's talking about AI, and one of the use cases, or one of the best use cases for AI in radiology, seems to be for mammography screening. And we've had some pretty big research studies come out, a lot of them in Europe, like Masai and things like that, that have found that that AI can sort of triage mammography, so that radiologists can maybe focus more on the cases that might actually have cancer. What do you think about AI's promise in making mammography more efficient, and what areas do you feel AI could help you the most?
Yeah, so I mean, obviously AI is a huge buzzword across, the whole world now. It's affecting almost every industry in the entire world, automotive, healthcare, just efficiency everywhere. So, but really in healthcare, we're always slower to adopt things, and we have to be really in tune to what's actually helping. Not just like for return on investment, but also improving patient outcomes and making sure that's actually demonstrable. Helping radiologists decrease burnout. These are all important things, and AI can definitely help with that. In the breast imaging space, I would say the most important thing that it can do, there's so many companies out there that can potentially have an algorithm that can detect certain lesions and make a case score as to, how much of a chance is this finding on this mammogram likely to have cancer. Okay. And that's a very powerful thing, as long as your data is good and everything's been vetted properly and that it's accurate. So several companies have proven that they're differentiated from others and have very good algorithms to detect breast cancer or even flag certain things on the many mammograms we'll read. So look at our list right now. The computer's actually behind you. We have like 1,000 unread screening mammograms. Now, we're a large practice and we have 20 radiologists that can potentially read these, but we're not working every day. There's maybe 5 or 6 of us working every day reading on these screens. So if you have 1,000 mammograms, we really need to be able to filter down that list to finding which ones are the ones that are most likely to have cancer. Let's try to read those first. And without a radiologist having even dropped eyes on it, AI can help do that by running it through their algorithm, and it can put at the top the highest case scores of the ones that may, have a high chance of having breast cancer. And we can sort our list that way and divvy those out to be read in an efficient and timely manner. So in my opinion, it's really about case triage, where it can help in breast imaging. And, breast cancer and screening mammograms, like the perfect thing for the AI algorithm to evaluate, because very, should be consistent quality, always the same types of images, right and left breast, always done with the same type of equipment, and really reproducible as to the output. So when you can filter a list by case score and read the ones that are most likely to have cancer first, you're actually helping everybody down the line. You're helping the patients get diagnosed faster. You're helping them get the biopsy faster and being taken care of faster. And also, you're helping the radiologists by making sure they're spending most of their time reading the ones that are more complex, the ones that were flagged, versus the ones that are, probably normal or most likely to be normal. You'll read those much quicker as long as you have high confidence that the algorithm is good, which is also a powerful tool. So in general, everybody's efficiency goes up when you have tools like this implemented in your practice.
Very good. And are you using AI right now in your practice?
So we're trialing, like we're using Hologic Genius AI right now, which has actually been very useful. And we are working on getting the ability to actually filter the list based off case score, and potentially even breast density, so we can focus on the ones that are more important first. But we are actually starting to use the 3D CAD, which is much better than what 2D CAD used to be. And AGFA has made it pretty easy for us to toggle exactly to the findings on the 3D stacks. And I believe Hologic Genius AI has a good product that doesn't mark absolutely everything. So I'm actually only spending my time looking at the few things that I would have probably looked at anyway as a breast fellowship trained radiologist. But also, when you're fatigued and you're on like your 50th or 60th mammogram, this is a really good tool to help you stay sharp and keep you on your toes the whole way until your lists are complete. I would say well received.
Yeah. So we are going to do questions toward the end of this panel discussion, but we did have one come in right now from Brooklyn that is pretty relevant to what you're talking about right now. Do you think AI will replace CAD? CAD being the older computer-aided diagnosis,
Yeah, I mean,
AI based.
Old 2D CAD is nearly useless. Like I do not look at 2D CAD. It's actually a waste of my time because old 2D CAD would just mark a bunch of things like calyx or clips or even sites that are known surgery. That's not intelligent at all. Like AI is way more intelligent. It should understand from the multiple priors that you may have that this patient had surgery in like 2006, and those calcifications are stable or getting coarser over time. Just like a radiologist would have thought it through by seeing a timeline of something, right? You can teach AI algorithms to understand how even a breast imager thinks. And it's even smarter because it could probably procure information from like Epic if you have a EMR that has a history of the cancer or a history of what their pathology was, to be even smarter in your interpretation. So it won't just, like old CAD would flag a benign finding, but new CAD, like future AI enhanced CAD, really shouldn't do that. It should only focus on something new or changing or different or highly concerning. So yes, I think it will. It's just going to take some time.
All right, very good. Kyle, can you speak to AI from the vendor perspective? No, AGFA makes enterprise imaging software, and you're not necessarily focused on developing AI algorithms, but how does it work from your end? And how do you kind of integrate that into what you offer and what people are using?
Yeah, well, Dr. Patel did a really good job of, defining his experience. And we see this a lot. There's essentially two different approaches we're seeing. One is more of a front end AI or some algorithm running at the device, at the modality itself, or as part of the vendor solution. Some are adopting AI more built directly into the imaging platform, or some image AI platform itself, where they're hosting multiple AI solutions. Really, both approaches work. What we want to focus on is how we going to, as part of your enterprise imaging workflow, integrate AI results naturally. If it adds clicks, if it forces radiologists into another system, if it just adds more information without being able to utilize that information effectively, it's not going to be maintained long term. We're going to find other ways to solve this. So one of the areas where, maybe additionally beyond what Dr. Patel was describing, that we've seen some acceptance here is around breast density. Breast density, sometimes dependent upon the organization, is not as standardized. You still have addressing this via visual biorads. There's a lot of subjectivity there, some volumetric tools, which kind of removes some of that subjectivity and makes it a little bit more objective, but there's still some discrepancies between different volumetric tools. I think AI has a real promise here on taking that a step further with creating a higher level of consistency. And that's going to matter as we're increasing volumes, creating a density classification across all modalities, all providers, all techs, everything that goes into this. We've seen this with one of our customers who implemented a density algorithm, and it really led to a significant increase in the amount of classification of dense breasts, because some of the rads were still using some more outdated methods for calculation. So creating that standardization led them to have a pretty significant increase in the number of follow-up ultrasound and MRI exams for their patient population. And the early results is encouraging because we are finding some early stage cancers in that group that's really going to improve patient care. So I think beyond, there's two sides for breast imaging and AI on lesion detection and lesion management across historical exams, as well as just creating a level of standardization for breast density scoring, which really ultimately is how we want to essentially look at AI results. Is how is it going to drive better workflows? How is it going to improve the radiologist day-to-day reading capabilities?
Yeah, exactly. Another area would be risk analysis, and that's starting to become really important right now. Is being able to take mammograms and with density and some other factors, figure out what's a woman's chance of having cancer in the next 5 to 6 years, and then you can kind of tailor screening to them. Collin, can you talk a little bit about what the role that a strategic partner like AGFA plays in helping breast imagers like Dr. Patel, delivering to them more comprehensive patient views for better clinical outcomes?
Yeah, so I think it really kind of boils down to a few pillars that we've really already kind of talked about today, but just to, maybe reiterate that providing that holistic view through a longitudinal health record, taking into account those various modalities, imaging types, maybe even outside images, all of those things to really give you the full picture of that patient's health would be a big one. Another, obviously, optimizing those workflows, things like intelligent work lists that Dr. Patel was describing, as well as kind of leveraging those even into some orchestration where we maybe kind of then send those cases to specific readers or groups of readers to manage those cases as well, and then embedding those advanced diagnostic tools, including AI, right? Like Kyle said, not giving the radiologist another button click or another applet to launch to get that information. We want to make sure that it's native in the viewer, using it in a work list, using it with tools and buttons that the radiologist has already gone through applications training for, right? We don't have to deploy brand new training every time we put a brand new button in. We want to make it very seamless for them. Really all to then kind of enable that streamlined reporting, right? So then using those values in a meaningful way. Also, as we start to look at, more FHIR-based implementations as well, to actually enable some of that streamlined reporting where we can then pass those measurements in from, various AI vendors that may be sending information over, really just to, again, ensure better clinical collaboration and, again, those patient outcomes.
Very good. So I think we're going to be going to questions in just a couple of minutes, questions from the audience. We've got several that have already come in. So thanks, everybody. Just hit that Q&A button at the bottom of your screen there, and we'll get to your question. Would like to close this part of the webinar, though, by maybe talking a little bit about what advice you might give to sites adding breast imaging to their enterprise image management system. And Dr. Patel, can you go first? And what kind of words of wisdom do you have for folks out there?
Yeah, I mean, I think one of the biggest keys is you really have to prioritize like seamless integration. You got to make sure mammography, ultrasound, MRI, all visible in one place, all in one workflow. And you should really prepare for future AI integration into these tools as well. If you have robust PACS, like you should also have it integrated with your EMR and your dictation system. So everything is in sync. And if you open up a patient jacket in the PACS, it should open up in the EMR. And if you want to start dictating it, it should be all integrated without too many clicks, just like we'd said before. I'd say, I know everybody has difficulty with hanging protocols. If you're a radiologist, hanging protocol is your most important thing. If that was perfect every time, that would be great. We know it's not all the time, but if you spend a lot of time up front to make that better, you will have a better experience and probably have 15 to 17% more efficiency in your day if you just focused on that up front. But yeah, those are the main things. Pay attention also to real-time collaboration tools in breast imaging. We're always dealing with technologists and other clinicians, and you really want to be able to seamlessly communicate with them as well. And I think COVID exposed that to a large degree by, when we had the inability to see our technologists or have them walk into the room like they did before, now we needed ways to talk to them and tell them to get different images without them actually being there. And so that made collaboration tools become a very important thing too. And now we're nearly dependent on that. Our day-to-day workflow is dependent on good collaboration tools that are even chat boxes and and sharing of images to our clinicians.
Collin, any advice from you to sites that are considering getting their breast imaging into their image management system, enterprise image management system?
Yeah, absolutely. I think maybe is equally, maybe a little bit less important than hanging protocols, but still very important. Definitely those workflows. So really having a really good understanding of, how your radiologist works with your technologist. So again, things like collaboration are huge when we're talking about that. Being very aware of, are your radiologists looking, as a group or as individuals of different AI algorithms that they may want to bring in. So really keeping all of those things in mind when you're talking about your workflows, because it's great if we can get all the images together, into one enterprise solution. But if we have no workflows to really structure them, it kind of falls apart, right? So we want to make sure that those are really top of mind when you're talking about introducing breast into an EI system.
Great. Kyle, how about you? What kind of advice do you have?
Yeah, I have to agree with what's been said to this point. The key for us, as an enterprise imaging vendor really is, how are we helping you standardize a kind of governance over your entire enterprise imaging portfolio? And if you have a governance model already in place, breast imaging as a whole should be a natural foray into what your governance structure looks like today. One thing maybe we touched on a little bit is, again, breast imaging radiologist specialists are not sitting in a room just scan after scan after scan. There's a lot of other tasks that they do, and making sure that you're having the right collaboration tools, having the right ability to see the entire patient jacket, the right relevancy rules set up to be able to curate an environment for the radiologist is extremely important. And then how that will layer into your enterprise strategy approach to how is this going to integrate into access for patients. We touched on that earlier. So again, for us, how breast imaging is kind of going away from just standalone, we're just going to do all of that in separate systems. It really should become more and more a holistic aspect of your enterprise imaging approach.
Definitely. Some great advice from our panel. So we're going to be taking questions from the audience right now. Once again, hit the Q&A button at the bottom of your screen there, and we'll get your questions in. Dr. Patel, a question for you. Do you currently use risk models in your practice? So breast cancer risk models. What are your thoughts on image-based AI risk models, such as those from iCAD, Therapixel, Lunit, and others that are positioned to replace long-term subjective models like Tyrer-Cuzick? So Tyrer-Cuzick being, an older model that's not really image-based, that's more like, density and family history and things like that. Where do you think things are going to sort out between these two types of estimating breast cancer risk?
Honestly, I think this is really institutional dependent, because now you're also having to, it's not just radiology that's using this information. It's oncology, it's your pathologists, it's your surgeons. And so everybody as an institution needs to come together in a consensus, or even as a high-risk program, and decide which is the risk evaluation tool that you're going to use as an institution to make sure you stratify these patients and take care of them. Our institution right now particularly is using Tyrer-Cuzick 8 because it's easily acquired in the information. It does deal with breast density. It does have questions that can be acquired by the technologist, and then we can get the numbers very quickly and put them into our reports to stratify these patients. Now, I know many companies are coming up with their own risk assessment models that may actually even be more accurate, and some of them have been actually, or at least touted as being more accurate. And I've mentioned this to our staff as well in our community, but the surgeons, the oncologists, the pathologists, everybody has to get together and decide what is the path that they want to choose as an institution before you go and make those large changes. It will probably go the way of what AI tells you, risk is.
So question here, I think this is either for Kyle or Collin on the vendor side. Is AI integration for multimodality assessment into centralized patient report generation realistic? And if so, how far off are we in accomplishing that? So the question here is, that in addition to AI being used to analyze images and find cancer, AI is also being used or being developed for generating reports. So how realistic is something like that?
I mean, this is like already happening. And if we started using a Nuance's smart impression generator like a year ago. This is an immediate game changer, like immediate. You dictate all your findings, and then basically you press a button and the impression is generated. Okay, based off all the thousands of cases you've read that are just like that one, it already understands your language and how your dictation style, and you literally press a button and you've generated an impression, which is pretty accurate. Like most of the time, I really have to make a few edits to do this, but it's going to get even better. And there's companies, Rad AI does this as well, where I think it's Omni reporting or Omni impression, where basically you can already start integrating some of the AI findings or even some of the measurements into the report directly. And as soon as you click on a comparison in the PACS, it could actually add in that comparison into your report. And you can also start in real time, it's generating certain findings that are from your models. And then you can press a button to generate in the impression or have it going real time. This stuff is happening already. It's getting better every day. And people who are not using this are missing out.
How much time do you think it saves you?
At least 15-20% a day for me. If I'm on not in breast imaging, I would say, because we're a little different in how we interpret things and use Bio-Rad's code to do things. But for like my inpatient and outpatient and ER shifts, it's like 100% of the time I'm using an impression generator, and it's saving me 15 to 20% of my time on a shift for sure.
Interesting. Kyle, do you want to? Yeah, go ahead.
Yeah, I think and I could be reading into the question, but one of the aspects of the question around multimodality aspects of breast imaging and perhaps a multimodal AI algorithms that are taking into consideration multiple exams on the same patient in creating a score or creating some interpretation. And we do see movement into this. And I think time will tell on how adopted those types of tools are. But, to Dr. Patel's point earlier, I think all of these things have to be considered when you're making a final diagnosis. You don't want to just read the image in front of you if you have historical exams to compare that calcification against. Is it new? Is it old? Etc. So I think that one is the ability for the algorithm to see the historical study in context of the current active study, as well as multimodality images or multimodal AI, which takes into consideration perhaps the mammogram as well as the MR and color representations mapping. So I think we will see more of this multimodal approach for breast imaging. Again, guesses are really anywhere from a timeline on I think the adoption of that.
Let's double back a little bit to the discussion over the workforce issue. And one of the things that we haven't really touched on here is tele-mammography. The idea that you can acquire a mammogram in one location and send it off somewhere else and have somebody else read it. Dr. Patel, do you think tele-mammography is kind of a realistic solution to some of the workforce issues we're seeing, and if so, like what do you need on the IT side to do that?
Yeah, so that's a good question, and it's I'd say a little probably controversial between some breast imagers and others, but there are patients in rural areas and community areas that are just not reachable, don't have radiologists in the area. You really need to be able to help them. Like they don't have the ability to drive like 3 hours to go into a traditional breast imaging center or academic center. So telemammography, it is a thing. We haven't adopted it yet, but we've been talking about it for about a year or two. And logistically, we're just trying to figure it out. But I did ask Dr. Margarita Zulli, who's at Pittsburgh. She's just a fantastic radiologist. She usually speaks at SBI about very important topics in breast imaging. And she did speak about telemammography. And I believe UPMC actually is using it for one of their radiologists in one of their community places. And it's met with great praise. And they're actually able to do it because their PAC system is able to acquire images and make sure they can get it to a list for a particular radiologist to read. And the way that the breast imager communicates with the technologist is via like a laptop and more robust communication tools that they've set up, and even video conferencing real time. So the problem is, like most breast imagers, we want to see the patient face to face. Sometimes we have to do a clinical exam of a palpable finding. And so obviously with telemammography, you can't really do that. But in that case, you have to really trust your technologist or potentially even have nurse practitioners assisting with this type of workflow. But I will say telemammography is not even possible unless you have like an enterprise imaging like AGFA provides. And then you as an institution can decide yourself how you're going to do with the communication and the physical findings. But it is a thing, and it's definitely something that's positive for patients who may not be able to have the access that other people do.
Very good. Collin, can you speak to maybe what AGFA offers and how you can kind of ease some of these challenges with your enterprise software?
I can take on the approach of what we're doing from a remote access perspective. So I think one of the aspects Dr. Patel said is there's certain things that you just can't do virtually, but from a image access and ability to have access to multimodality images, the entire patient jacket from anywhere, as we discussed earlier, some of these studies, DBTs especially, can be quite large. The movement of that data becomes very difficult for certain vendors or certain solutions. What we've done with our streaming client and streaming technology is essentially being able to server render and ensure that all applications as much as possible are running at a server location. And in the browser, you're going to see what's being rendered at the server. And what we do is we move the pixels. So regardless of how large of a file set that DBT is, we're essentially just moving the pixel data, which is a much smaller amount of data, to the screen. Now, this can vary depending upon what monitors you're moving, because essentially we need to paint every pixel on that monitor. We do have smart pixel technology, which essentially allows for some intelligence in the browser memory on how much pixel memory we actually have to continually push. But essentially what we're trying to support is your ability to work from anywhere, literally, in a browser environment with the right monitors and the right setup, obviously, but really reducing the amount of bandwidth and network need to push large data files from location to location across VPNs, et cetera.
Yeah, because these are really large files. Collin, anything that you want to add to that?
Yeah, I mean, I would just add that when we started down this path of this technology, we really started with Mammo just because we understood the need for this telemammography that we're talking about right now. And again, just that need to be able to really handle those larger Tomo data sets. So yeah, we've put a lot of time and effort into it with mammography kind of at the forefront.
Oh, very good. We've got about 15 minutes left for questions from the audience. Hit that Q&A button down there at the bottom of your screen. Question here from Miguel, and I think this is probably for Dr. Patel. Do you believe that long-term risk prediction models will increase patient appointment times in screening programs, or with the automation of the reading and triage process due to AI, should risk prediction focus on interval cancers? So interval cancers being, cancers that show up in between screening rounds. So I guess the issue, I think kind of speaks for itself there.
That's difficult to answer. I mean, risk prediction models, how good are they? But really, the more important thing is for institutions to actually have risk programs that utilize these models, but then get these patients seen by either nurse practitioners or staff that's capable of managing these patients and making sure they get the right things ordered routinely, such as genetic counseling if they need, routine screening breast MRIs if they need, and just making sure that those patients who potentially have higher risk are captured and followed in the way that they should be and given the attention they should be given. So really, it's like it'll be very difficult to find interval cancers, but the only way you're ever going to find them is if you have gotten the information that they are high risk and managing them appropriately with the right tools.
One question that I have about, the mammography has changed so much and breast screening is changing so much over the years. How much awareness among patients do you see of issues like breast density? Because I know that there's been a pretty active movement in educating women about their breast density and about the fact that X-ray mammography isn't really great for imaging women with dense breasts. Are women aware of that? Are they kind of getting that message?
I think so. I mean, there's been a lot done politically and just, by the ACR, SBI, several institutions that are just making sure women are aware of their breast density. And in fact, many states, every state actually, I think, is required to have a breast density statement or some type of option for patients who potentially have dense breasts. And there's particular verbiage in some states, like Georgia actually has verbiage that says if you have dense breasts, that this statement should be in your report so patients are aware. And then so we put it in our reports, but we also want to make sure as an institution that we take care of these patients, right? Like, and the only problem I see is, yes, I think it's becoming more aware. Like patients understand that there is a difference between non-dense breasts and dense breasts, and the dense breast may be higher risk. But what do you do for them, right? If they're higher risk or they potentially have increased risk for having breast cancer just because they have dense breasts, you need to be able to help them by offering things like 3D mammograms or contrast enhanced mammograms or whole breast screening ultrasound or even screening breast MRI. But the more important thing is somebody's got to pay for that, right? And insurance companies, and they should probably pay for these things. So in Congress, there's multiple people trying to work on things. One of them in particular is called the Find It Early Act, which is really trying to help the patients get the things that they need that we are required to tell them about also paid for, right? Because our whole goal is to help patients, save lives, decrease mortality. So that's what we're trying to do, but we just need the help of every moving part, and that's not always simple.
Yeah, and there have been a
But
number of
also
studies.
say
Go ahead,
this
Tom.
goes back to really looking at this as a enterprise aspect of the business, right? Like I think what Dr. Patel mentioned earlier, if you're going to make a decision on a change of the approach to any of this, what are the other aspects that you need to think about? Is it going to increase MRI volume? Is it going to increase, ultrasound volume? What approaches are you taking? And what are the things you need to make sure that you are putting in place to effectively roll out this change so that it doesn't create other issues for your organization? And for the patients, how are you going to adapt to these regulatory changes? What educational programs do you need to put in place? So if the patients are going to have this statement about breast density in every single report that they get, you're going to get more questions about it. We already see it. This is causing more follow-ups for ultrasound or causing more follow-ups for MRI. What are you going to do to make sure that there's education programs in place? What are you doing for your referring physician population and NP population to ensure that the proper communication of those results is managed and the patients really understand why you're recommending what you're recommending or why this statement is now in your report?
Yeah,
if it was 2 or 3 years ago.
Yeah, we have a comment from Crystal, who's kind of taking almost a patient perspective, which is, yes, we're all aware of breast density, but there's no consistent answer around now what, meaning, if you've been told you've got breast density, what exactly are you supposed to do? And if I'm not engaged in annual mammography screening, what are my realistic options, including interval screenings? You can't tell me I have des breasts and leave me without options. So I think a great resource is desbreastinfo.org, which is a website that has a lot of information.
I shared that link with you, but this is what we utilize. Desbreastinfo.org is, I think, a great website, and it's based off up-to-date information on and very simple information for patients, for physicians, and even resources for patients and clinicians about dense breasts.
Yep, and I just shared that URL to everybody. So that is a great resource to go to learn more about that kind of thing. So everybody, we got a few more minutes for questions. Please hit the Q&A button at the bottom of your screen. Dr. Patel, if you had to prioritize one thing, what should practices be doing to better handle increasing mammography volumes?
Well, staff. You got to have staff. But as far as for a radiologist, it's basically you just need to be able to keep your radiologist happy and keep your technologist happy. You have to have seamless integration with everything you do, and that will basically keep you happy and allow you to do the volumes that you need to be doing. So that's a very complex thing to answer in like one simple question, but keep people happy. The volumes will come if you have the staff to actually do it, and you pay attention to keeping everything integrated and seamless.
And Kyle, doubling back on the AI issue, a lot of people are kind of holding AI up as a possible solution to a lot of these workforce issues. Is AI a solution? Just kind of off the top of your head?
I think it can be. It just depends on what your organizational approach is and understanding that, there's no silver bullet to this, right? It is an operational organizational decision, and one decision always creates a downstream effect, as we've mentioned. So if you're trying to think about tools that you're going to bring into your arsenal to support your radiologists, ensure that those tools make them more efficient, and make sure that you're working with your enterprise imaging vendors, your PACS vendors, whoever, to make sure that those results are making them more efficient, not just giving them more information to think about or have to decipher. And that's, I think, the key to all of this adoption is what's the approach towards adoption and utilization so that the end goal of efficiency and better patient care is achieved.
Yeah. We have a quick question from Stanley. How is breast density reported to patients with the new FDA requirements? And Dr. Patel, I think there's like a letter or something, like there's specific verbiage that has to be communicated to them.
There's specific verbiage, and it's on the FDA website, and every state probably has their own version of it as well. But it's all mandated basically by the government that you have to anyway.
And how does that interface with the state regulations? Does what the FDA has done, does that supersede the state rules? Because before the FDA acted a year or two ago, a lot of states were adopting breast density reporting requirements.
Yeah, I can't remember exactly, but I'm pretty sure the federal is the overlaying one, but each state has their own little layer on it. But there's enough overlap between the two that it's effectively it's fine for each different purpose. Like you can use one or the other, and it should be okay.
All right, very good.
I think we have to tweak ours in Georgia to be accurate, but that's state specific.
Okay. Question here, maybe for Kyle, and it's about the black box nature of AI. So one of the kind of the criticisms of AI, at least in the early years when it was coming up, was that it's a black box. We don't know how it's making these decisions in there. Do you think that concerns about AI's black box nature are going to hinder clinical adoption, or do you feel like people are maybe getting past that a little bit?
I think it's dependent. There's no single one answer to some of this. It's going to be dependent upon your physician population, primarily, on their adoption of it or their acceptance of it. What we can say, though, is the black box nature should not be as difficult to overcome conceptually, as long as you're following what we would consider good scientific proof points of what's the study show, how is this working, and how are you going to be able to incorporate the results into your practice. If you can look at the scientific studies, look at the research, and the validation is there, and you're okay with adopting in a trial method or adopting these tools initially into your own patient population and into your own series study sets, you've got to be able to overcome the hurdle of not understanding how it works and accept that the results are accurate.
That's a great point. I mean, my car is, as far as I'm concerned, a black box to me, whatever's under the hood there. But
most cars are now.
Yeah, for sure. All right. Well, on that note, I think I'd like to wrap things up. I'd like to thank everybody for being with us today. Dr. Jay Patel of Quantum Radiology, Kyle Souligne of AGFA HealthCare, and also Collin Bauer of AGFA HealthCare. Thanks so much for being with us today. I really enjoyed our discussion.
Thank you. It was great.
Thanks, Brian.
Thank you so much.
And most of all, I'd like to thank everybody else out there in our viewing audience. Thanks for signing up for this webinar. And we really, we wouldn't do it without you. So we really appreciate your time. Signing off for the Imaging Wire, my name is Brian Casey.